Hello my fellow college and esteemed audience. Thank you for watching the student project of small group discussion B6. My name is Putu Nadia Nandita Prasanti and my last 3-digit student number is 150. On this occasion, we would like to present our student project entitled Intestinal Perforation. But before we dive into the details, let me introduce our team. And for the first speaker, time is yours.
Hello everyone, my name is Nimadi Aprilia Rusisyanti with 3 last digits of student number 229. I will explain about the background. Perforation is an abnormality of opening in an empty organ. The word comes from the Latin perforatus, referring to bore through. A disease affecting the entire hollow organ, down to the peritoneal defect with intraluminal packing, is said to cause perforation. A potentially fatal consequence that can arise from a number of disease processes is intestinal perforation, which is defined as a break in the intestinal wall. The underlying etiological causes that give rise to intestinal perforations differ in industrial and developing nations. The most common causes in developing countries are infectious disorders like typhoid, tuberculosis, and HIV infection, while non-infectious conditions like cancer and diverticulitis are more prevalent in developed countries. Many medications, including NSAIDs, corticosteroids, opioids, and calcium channel blockers, have a negative effects on the mucosa and raise the risk of perforation. Intestinal perforations management depends heavily on early diagnosis and intervention. Certain indications of perforation, such as lucency over the liver shadow or football sign, can be identified with the use of imaging investigation such supine abdomen X-rays, facilitating prompt management. In many cases, surgery is required to close the perforation and stop more problems. However, a number of variables, including the patient's general health, the underlying reason of the perforation, and the promptness of medical intervention, might affect how well the patient responds to therapy. That's all about the background. Thank you.
So hello everyone, my name is Adelia Pramesti with my last 3-digit number 165, and here I'm gonna mention about the problem formulations and objectives. The first one, problem formulations. What is the definition of intestinal perforation and epidemiology? What are the etiologies of intestinal perforation? What is the pathophysiology of intestinal perforation? What are the clinical manifestations of intestinal perforation? How to diagnose intestinal perforation and what are the differential diagnoses? How to treat and manage intestinal perforation? What are the prognosis and prevention of intestinal perforation? So the objectives are to describe the definition of intestinal perforation and its epidemiology, to explain the etiologies of intestinal perforation, to explain the pathophysiology of intestinal perforation, to describe the clinical manifestations of intestinal perforation, to explain steps on diagnosing intestinal perforation and its differential diagnosis, to explain steps on treating and managing intestinal perforation, and the last one is to explain the prognosis and prevention of intestinal perforation. So the next one is the benefits. First, theoretical benefits. This paper can be used to increase knowledge about intestinal perforation, its definition, epidemiology, etiology, pathophysiology, clinical manifestation, diagnosis, differential diagnosis, treatment, management, prognosis, and prevention. So, the practical benefits for readers are being a source of information and references regarding intestinal perforation. Practical benefit for the writers is to increase the experience and knowledge of the writers in writing scientific works. The results of this work are expected to be a source of reference for the writing of other scientific papers. Practical benefit for academic institutions is it can be used as a reference for academic institutions to develop knowledge about intestinal perforation.
Hello everyone, my name is Sarah Putri Bungaran with 078 as the last 3 digits of my student number, and this time I'm going to explain about the definition and epidemiology of intestinal perforation. Intestinal perforation is the loss of continuity of intestinal wall due to wound or injury to the intestinal wall mucosa. Intestinal perforation can result from many factors such as inflammation, infection, trauma, obstruction, or due to invasive procedures. Speaking of epidemiology, 1 to 7% incidence of colon perforation occurs in pediatric patients. In adults, the most common etiology of intestinal perforation is ulcerative disease. Duodenal ulcer is the cause of perforation at 2 to 3 times higher rather than gastric ulcer. In geriatric patients, the most common cause of intestinal perforation is due to appendicitis. Risk factors for bowel perforation vary by geographic region. Sociodemographic and environmental factors also play a role, such as poor hygiene and population density in developing countries. And maybe that's all for me. For the next speakers, time is yours.
Greetings, Doctor. My name is Gabrielle from Rustafita with my last registration number being 118, and today I'd like to talk about the etiology of intestinal perforation. Simply, there are four mechanisms that can lead to intestinal perforation. First, there's ischemia, such as bowel obstruction and necrosis. Second, there's infection, including diverticulitis and appendicitis. Third, there is erosion, such as ulcerative disease and malignancy. And lastly, there is physical disruption, including trauma and iatrogenic injury. That would be all from me. Thank you.
Now let's talk about the pathophysiology of perforation caused by ischemia, infections, erosion, or carcinoma, and physical disruption. So perforation due to ischemia occurs when perfusion is reduced due to obstruction in the bowel. So obstruction causes the gut wall to become distended, which results in a wall necrosis that could lead to perforation. Bowel obstruction can be caused by tumor, foreign substances, inflammation, strangulation, herniation, and patient with past history of surgery. So ischemia can also be caused by decreased end organ perfusion as a result of thrombotic or embolic illness. This explains why old people, smokers, people with coronary artery disease, and people with clotting abnormalities are more likely or prone to experience ischemia. So, nextly, we talk about the perforation due to infection, which often happens due to diverticulitis or appendicitis. Trapped fecal material alongside stasis in diverticulitis and appendicitis often leads to increased intraluminal pressure alongside infection. This causes localized abscess or frank perforation. On the other hand, inflammatory diseases like Crohn's disease could induce inflammation in the wall, which leads to perforation. Erosive perforation, on the other hand, happens because, for example, of ulcerative disease or tumor. So, ulcerative disease causes perforation by direct erosion through the bowel wall. For example, peptic ulcer caused by overproduction of acid or lack of protective layer, whereas tumor, mostly adenocarcinoma, causes perforation by simply invading the bowel wall. Lastly, the physical disruption due to blunt penetrating trauma could easily cause perforation due to its mechanical force being inserted into the bowel wall. Other than that, instrumental perforation, or as we call iatrogenic perforation, could also happen by using endoscopy, which could happen in patients with weak bowel wall, for example, for pediatric patients, which really rarely happens, or weakened bowel walls, for example, patients with corrosive damage.
Greetings, my name is Arianda Bilamadrian with the trail last digit of student ID number 188. So the intestinal perforation clinical manifestations may vary depends on the site of intestinal tract that is affected by the disorder or disease. Symptoms indicating a perforated intestine grow gradually and worsen with time. Perforation can be difficult to recognize because it is usually occur as a result of condition that is already painful or contributes to other symptoms. For upper intestinal perforation, such as esophageal perforations, can present with acute onset of chest pain, trouble in swallowing, fever, nausea, and vomiting that sometimes comes with blood. In addition, gastroduodenal perforation present with acute severe abdominal pain and tenderness when touching the abdomen. Colon perforations, on the other hand, usually progress slowly and are associated with secondary bacterial peritonitis or localized abscess, such as delayed symptoms and abscess that mimics an abdominal mass and sepsis.
First of all, my name is Devalinda Ramadan with relast number 016. I will tell you about diagnosis of intestinal perforation. Diagnosing intestinal perforation necessitates a comprehensive approach, beginning with anamnesis, the cornerstone of medical history evaluation, through detailed questioning. Clinician gather incidental information regarding predisposing feature, such as pervasive abdominal sugaries, underlying gastrointestinal condition, or recent trauma. However, the efficacy of anamnesis may be limited by patient ability to recall pertinent details of the presence of atypical symptoms, underscoring the need for supplementary diagnosis methods. Physical examination play a crucial role in detecting signs suggestive of intestinal perforation. including localized tenderness, guarding, and rigidity upon palpation of the abdomen. Key elements of the examination include palpation, auscultation, and the observation of signs of symptoms inflammation. Laboratory investigation complement the diagnosis process by identifying systemic inflammation, electrolyte imbalance, or metabolic derangements associated with intestinal perforation. Imaging studies such as abdominal X-ray, ultrasonography, or computed tomography CT scans serve as invaluable tools in confirming the diagnosis of intestinal perforation.
Hello, my name is Kadek Bintang Aristia Putri with my last 3 digits of my student number is 056, and I will explain about the differential diagnosis of intestinal perforation. Upper GI perforations cause the perforations event that generally caused by peptic ulcer disease that differs with intestinal perforation. The most common cases of peptic ulcer disease is Helicobacter pylori infection. Perforations event is also a final result of bowel obstructions with free intraperitoneal air that is visible in the imaging. In rare cases, free intraperitoneal air may arise from pneumatosis intestinalis, which can be a clinical sign of particularly immune reaction, infection, bacterial abscess, suppurative cholangitis, and conditions that may necessitate surgical intervention. Colonic perforations often accompanied by reduced stool output that similarly with chronic constipation, which is marked by unpleasant defecation, hard or infrequent stools, and a sensation of unfinished defecations because the changes in bowel or anorectal function. Less commonly, malignancy or traumatic perforations are possibilities with free air located near the area of perforations, with possible abscess formations present due to the leakage of stool into the peritoneal cavity. Abscess also could be seen in ileus disease as a result from intraperitoneal abdominal infections, peritonitis, certain medications, and post-operative complications. That's all from me, and the next slide will be presented by my friend. Thank you.
Let me introduce myself. My name is Amanta Petrana Teobat with last 3 student numbers 108. So let me continue the presentations. The initial treatment for all patients with intestinal perforation disease is non-surgical treatment. The treatment consists of bowel rest, fluid resuscitation, antibiotics, and abdominal examination. Intestinal perforation patients with signs and symptoms lead to septic ulcer require an intravenous access in initial treatment to stabilize the hemodynamic. This includes giving a fluid resuscitation through intravenous route. Early administration of antibiotics targeting the gram-negative and anaerobic organism is important in order to avoid further infection, which may lead to complications. Nasogastric decompression should be carried out in patients with distal intestinal perforation. Along with that, patients should be made NPO or nothing by mouth. Patients with appendix perforation are classified as low-risk community-acquired intra-abdominal infections group, excluding risk factor related to antibiotic resistance and failure of treatment. Patients with stabilized hemodynamic and no sign of peritonitis can be treated by non-surgical procedure, such as antibiotics and observation by surgical team. Localized and controlled perforation treated by drainage of the fluid with radiology guidance. However, patients with septics and peritonitis or conservative treatment failure with sign of septic development need a surgical intervention.
Greetings, doctors. My name is Janice Tinchan with last 3 digit number 119, and I'm going to explain about the treatment and management of intestinal perforation, which I'm going to focus more on the operative management, which we know is very required for patients that are not responding to resuscitation or stabilization mentioned before by my friends. And so this time I'm going to explain about the laparotomy and laparoscopic procedures, being laparotomy the foremost choice for intervention regarding intestinal perforation cases. So laparotomy involves cutting the abdomen wall, giving the surgeons access to the abdomen cavity, and determining the location and extent of the intestinal perforation. Simpler surgery may also be done based on the disease severity, stitching the perforation close to
to prevent infection and sepsis as an example. A study discussed the association between initial laparotomy and improved surgical results, which show that fewer healthcare costs and hospital stays and decreased rates of mortality and morbidity is related to the discussion. And on the other hand, laparoscopy is a minimally invasive surgical treatment. In addition to its high effectiveness in managing intestinal perforation, a small abdominal cut is made and a laparoscope is then introduced to enable the surgeon access to the abdomen. And depending on the severity, the surgeon may utilize laparoscopy to either eliminate the injured intestines or may fix the hole with stitches. Furthermore, laparoscopic repair for bowel perforation has superior outcomes regarding hospital stays, post-operative troubles, and recovery durations when compared to open surgery. Okay, that's all from me. Thank you.
Hello, my name is Putu Nadia Andita Prasanti and my last 3 digits of the number is 150. Today, I will talk about the prognosis and how to prevent the risk factor of intestinal perforation. Factors influence the intestinal perforation, including patient health prior to perforation. Factors such as age and comorbidities also play a crucial role. Older patients and those with other medical conditions tend to have a worse prognosis due to complication. And then the cause of perforation, whether it's benign or malignant. Malignant causes such as cancer tend to have a worse prognosis. And then timing of treatment. Delays of more than 6 hours after diagnosis will increase the morbidity and mortality. And patients who cannot tolerate or choose not to undergo surgery generally have a worse prognosis. Recovery time for intestinal perforation varies depending on several factors. The initial hospital stay is around 10 to 14 days if there are no complications, but full recovery can take several weeks to months. Early management of intestinal perforation is also crucial. Early severe complications include hemodynamic stability, bacteremia, shock, and sepsis. Late complications including hernia, fistula, bowel obstruction, delayed wound healing, pulmonary issues, thromboembolic events, cardiovascular issues, and ventilator support. Preventing intestinal perforation involves addressing risk factors and implementing strategies. Early diagnosis and treatment of conditions like diverticulitis and Crohn's disease are crucial. Minimizing NSAID and corticosteroid use and choosing safer alternatives can mitigate risks. A healthy lifestyle with a higher fiber diet, hydration, and exercise improves cardiovascular disease. And proper management of chronic disease like diabetes is essential, and preventive surgery may be considered for high-risk patients. That's all from me. Thank you.
I'm Angelica Fortunalawan with the student registration number 092. Now I will give the conclusion of our student project. Intestinal perforation, a critical condition, involves a break in the intestinal wall leading to severe abdominal pain, fever, and potential septic shock. The epidemiology varies, with infectious diseases being common causes in developing countries and conditions like cancer and diverticulitis in developed countries. Risk factors include medications such as NSAIDs and corticosteroids. Diagnosis involves anamnesis, physical examination, and imaging, with differential diagnosis including peptic ulcer disease and bowel obstruction. Early intervention with IV fluids, antibiotics, and surgery as further intervention is crucial for improving patient outcomes. For the recommendation, healthcare professionals must recognize the signs and symptoms of intestinal perforation for timely diagnosis and treatment, and emphasize preventive measures such as managing underlying conditions and reducing risky medication use. Continued research into both surgical and non-surgical treatment methods is essential to improve patient care.
That's all about our presentation. We would apologize if there was any mistake or inconvenience. Thank you for the attention.